team in the mechatronics work as Vice President of Research and Core Technology for the Restore Active Therapy Group. He oversees the design for the next generation of neural interface and algorithm technologies for the treatment of chronic neurological disease. In 2015, he was elected to the College of Fellows for the American Institute of Medical and Biological Engineering. He has a PhD from MIT in electrical engineering and an MAB in the physics and MBA from the University of Chicago. So Tim is very famous in this area. As I think, his talk will help us understanding what's happening in this field. So Tim, welcome, and very exciting. You join us and give a talk.
Thank you, Luming, for the introduction. It's my great pleasure to give you some highlights of the work going on at Oxford, but also I think it gives context to some of the trends that are going on in the field of brain stimulation today, and actually bioelectronic medicines in general. And also it's a relatively new field that I've been pursuing, specifically thinking about biological rhythms and how we might want to adapt brain stimulators to account for these rhythms and look to reinforce them. So I just want to acknowledge it's a team here for this topic in general with John Fleming, my postdoc who compiled a lot of the information in these slides, and then other things to get started with the disclosures. Of course, I have some industrial collaborations and industrial work going on myself. Most importantly for this talk, I want to point out that the Activa PC+S, Medtronic Summit RC+S, and the PicoStim Dynamo research tool are all investigational only at this time and not for commercial sale. And so once again, acknowledge just up front my team. And so kind of keep it as kind of the industrial team and the academics as well as my funders. So I'd like, especially with this audience in China, I think there's a real deep understanding of rhythms and timing, and I want to make those salient for everyone. So the rhythms are going and pervasive throughout the body at multiple time scales. So for, blood circulation to micturition going on multiple times per day, the sleep-wake cycle, of course, going on once per day, menstrual cycles at a month, and then at the extreme, the cicadas, the insects with hatch timeframes between 13 and 17 years. So all of these rhythms are actually foundational to the operation and optimization of physiological processes. And the disruption of these rhythms really could be playing a central role in disease. So that's really the basis for this talk, is thinking very deeply about rhythms and what we can do as scientists and engineers to engage those rhythms. Now, here on the right, is kind of a little snapshot of where we are with bioelectronic medicine as broadly defined, as I will broadly define it, in 2022. And you heard Professor Lee at the Mayo talking about systems in the brain, thinking about chemical sensing as an adjunct measure to electrical activity. So that'll treat, say, Parkinson's disease or epilepsy, of course, cardiac pacemakers, incontinence devices. All of these systems are looking to provide therapies for disease states. However, that first generation devices is really operating basically with a fixed pattern for the most part. And even algorithm devices such as cardiac pacemakers or the responsive neurostimulators for epilepsy are still relatively fixed with their algorithm based, not really considering the time of day. And oftentimes stimulation adjustments require manual intervention. So what our team is doing is stepping back and saying, how does stimulation actually affect these foundational rhythms in the body? And how might we consider that for optimizing and influencing rhythms to really improve the therapy that we can provide to patients? So our primary objective is really to think carefully about how we can design bioelectronic devices to both explore and then exploit these rhythmic processes. And that's going to be the topic for the next 30 minutes. So stepping back, the first generation of brain stimulation devices, and we're really focusing in on Parkinson's disease, at least now, the mainstream devices, and tremor. And these were modifications of historical cardiac systems with the chest-mounted battery and electronics, with the electrodes tunneled up through the neck, and then a stereotactic neurosurgeon, such as Professor Lee, would drop the electrodes into a specific brain target. Now, the issue, I would say, with us thinking scientifically and as technologists, is that the mental mindset of this was to replace what was historically an RF lesion. And you'll even say you'll hear people say it's a reversible lesion. And that notion of a lesion, by definition, is a static concept. So we make a change in the brain, and then it actually is there to stay. So what I want to do is pull us out of that mindset of a static process and think more about a dynamic system. So taking our mental model from a lesion and, to use one expression from Ed Boyden, how might the brain act as, or devices act as a brain coprocessor? And the idea there is to supplement was historically the actuator with additional sensors, and you just heard about chemical sensing and electrical sensing, processing those signals, and then based on how we're classifying and estimating the state of the patient, making the appropriate control adjustment to modify the actuator. And then, of course, part of that is to think about reinforcement so that we can continuously optimize how we're going about the treatment. And it's this optimization process, which is actually really critical, and thinking about what do we need to do beyond, say, open loop, but frankly, even beyond closed loop processes, and thinking about rhythms in general. So to make sure I don't lose anyone, I'm going to kind of step back and say that your kind of technical intuition for what we're trying to achieve is saying in the first generation of devices, systems are acting to a certain point like a furnace that was set, by the clinician. You set it up based on the best estimate between visits. And you kind of say, I'm going to hope I get the right level, but the weather's going to vary. People are going to come in and out of the house, and you've got to just do your best that you can. What we want to do is look for sensors, and similar to a thermostat, where we measure the temperature and use that to continuously adjust what the furnace is doing to optimize the control of what we really care about, which is the temperature in the room. But one thing I want to point out, which at least in the case in the thermostats in the United States or UK, which I'm familiar with, is that set point of temperature is not static. You will adjust it based on the time of day. So you might turn it down at night when you're trying to sleep. You might turn it up when you are getting up and going about your daily business. And so that rhythmic process is something that's still missing in a lot of our discussions as a field about closed loop systems. But taking this analogy, let's take a little snapshot of 2022 and just starting with a simple thermostat, is that there are examples that are being explored in Parkinson's disease. And Professor Lee made a reference to the Medtronic Percept, and it's currently in a clinical trial exploring these concepts. And the basis for it is the rhythm that's seen in the basal ganglia network of the brain. And so from pilot work with Andrea Kuhn back in the early 2000s, they were looking at the signatures measured off of electrodes placed within the basal ganglia and analyzing those signals in the spectral domain. So the x-axis is frequency, the y-axis is the power in that band. And what they would observe is that when Parkinson's patients were off of their dopamine, they might see a peak in this beta region around 20 hertz that was correlated with the Parkinson's symptoms. Then when the subjects were given their drug and their symptoms were relatively relieved, when they were, say, on their drug, as Parkinson's patients will or want to define themselves, you would see the reduction in that beta band. So then Peter Brown and his team said, what happens during stimulation? Do we see a similar effect? And so this is a plot. Now frequency is along this axis, time is going by, and you can see in that beta region, and this subject just happens to be a bit lower, about say 12 hertz, the excessive signal is there, and then they start to stimulate, staircase up the level of stimulation. And then in the region where symptoms were seen to largely be dissipated, there's a reduction in the beta band. And then they turn off the stimulation, the signal comes back along with the symptoms, and then the stimulation comes back on, and the reduction of the beta band is there. So this notion of a field potential that's measurable off the brain stimulation electrodes is the idea of basically the conceptual basis for building up a thermostat. So we can measure the power in this band and use it to control the DBS stimulator, basically 24 hours a day, 7 days a week. So that's kind of the state of the art of where a lot of translational studies are going. You know, as both Neuronic and Medtronic have clinical studies now being performed globally, and it'll be very exciting to see what the outcomes of those studies are. However, what happens during the time of day? So stepping back as a community, thinking about circadian rhythms, biological rhythms, and therapy optimization, it's important to note that many of the experiments that were the basis of these studies were actually performed during a small window in the day. So like at Oxford, people come into the movement disorders clinic and it'll say be around between noon to tea time. What are the ramifications for limiting the time that we're gathering data to such a small window of the day? What happens during sleep? What happens during a nap? What is the therapy? Should the algorithm be adjusted in any way? And are we actually optimizing stimulation appropriately? So just to show you that this is relevant, we're able to work with our collaborators and start to look at both Parkinson's disease and epilepsy. So using the tools, the chronic sensing tools, say available in the Percept, our collaborator, Simon Little at UCSF, configured the device in a Parkinson's patient to measure the power in the beta band in each hemisphere every 10 minutes and store it in the device. And so that's this LFP amplitude, is that kind of power of the beta over on average in a 10-minute window. And then the x-axis is time, but now not time on minutes or seconds, times on the order of multiple weeks. So this is months going across. So 1 week is actually shown in this bar. The red is actually stimulation titration being adjusted. And what you can see is that as stimulation is titrated, the extremes in the beta are going down, which one would expect. So theoretically, symptoms are improving. But the other thing you'll note on both hemispheres, right and left, is this very repetitive pattern. Every day there's a dip in the beta band, and that's actually occurring during the night. And so that key control signal that we're interested in, at least as measured on the Percept with its limited time resolution, seems to be disappearing. But yet here's the conundrum as a field. We know from patient reports and other clinical studies that stimulation does seem to help improve sleep. So if we had an overly simplistic algorithm doing this average, it would tell us to turn the stimulator off at night when we know from other clinical data inputs that we don't want to actually take that action. So thinking about the algorithm and the importance of how physiological rhythmic processes might be engaging with that algorithm are really salient in this example from Simon Little. Similarly, Greg Worrell and his team at the Mayo Clinic have been putting in these chronic sensing devices in both humans and in pet dogs. Pet dogs being another model for experimental medicine because the epilepsy characteristics of canines are quite similar to that of humans. So it's an excellent way to explore advanced technology, once again within the experimental medicine context of working with veterinarians and animal are basically 1 year snapshots. And then the spiking rate that they're seeing, we see this basically interaction of cycles at multiple time scales. So there's both the daily rhythm, which is very strong in both dogs and humans, and also kind of a 12-hour rhythm, but then also these rhythms that are going out over multiple weeks. And so many days, to multiple week patterns. And so what do we need to do or consider as clinical scientists, as engineers developing technologies to optimize therapies for this variation that's actually seen naturally in the physiology? This notion of a static setting, both in terms of stimulation as well as our therapy algorithms, might be suboptimal. So to explore this concept further, the team at Oxford, in partnership with both industry at Bioinduction, as well as other academic partners in the UK, such as Imperial College and Great Ormond Street Hospital at UCL, have developed the PicoStim Dynamo as a research tool. And what we've done here is go into the existing PicoStim platform, which exists, and it's a cranial mount device that is embedded in the skull, and then the 2 DBS electrodes can be placed using classic stereotactic neurosurgery approaches. And what we've done is then, I'll get into some details on the next slide, added in a research system with capabilities to explore adaptive algorithms for familiar bioelectrical signals like the beta band, but also 3-axis accelerometer for motion and posture, but also critically thinking about circadian patterns and how we might explore rhythmic stimulation patterns based on the time of day. So this slide is a little busy, and what I just want to highlight is that similar to my prior research of putting scientific instrumentation inside of devices, that's the same strategy that we've applied in the PicoStim Dynamo. So the blue boxes are kind of the core therapy that guarantees that any research subject will get their expected therapy that they get from, say, a standard CE mark device. So the stimulation, the electrode leads, the telemetry, the patient controller, and the like. And then the tan boxes are the sensors, classifiers, and controllers that are really focused in on exploratory research and clinical neuroscience. And so those are the examples we've discussed: the 3-axis accelerometer, a biopotential amplifier, a lot of effort going into the classifier to enable the sensing of those field potentials in the presence of stimulation. And then, of course, modifying the control policy to get a complete closed loop system. There are other elements, which I'll come to at the end, and the patient control and the like, which are on fallback modes and transparency to the algorithm states, which are really designed actually to ensure the safety of our research subjects as we're exploring these algorithms. So I want to highlight here that the circadian element is enabled by a real-time clock scheduler. So like many modern electronics, inside of the device, there's a real-time clock, and we can use that to keep track of time and say, based on the time of day, what is the appropriate action to take? Perhaps I want to have one stimulation setting during the day, one stimulation setting during the night, and that will be automatically handled by the device itself and not require the intervention of the patient. So with this research device and the NET PicoStim Dynamo, we really focused on this device that can do both the classic closed loop approaches, but also time-based, almost feed-forward stimulation adjustments. And so just to summarize, it's a cranial mounted device that's rechargeable. It can do the chronotherapy based on time, as well as motion and biopotential feedback. And we discussed some of the prototyping of this in a Frontiers in Neuroscience paper in 2021. So in the context of this talk, thinking about rhythms, I'm going to highlight a few of our example use cases. So the first was an experimental medicine trial building on the experience at the Mayo Clinic in a pet dog that was suffering from generalized DBS. And it was a severe enough level of epilepsy that the dog was going into status epilepticus. And so that would require a intervention with general anesthesia and then titration off over several days. And so the severity of the epilepsy warranted a intervention with the device, and that's what's shown in this CT. And so we were able to place the research tool on the surface of the sinus area. So we didn't actually penetrate into the bone, just slipped it under the skin. And then the electrodes were placed and targeted in the central median thalamus, which is a target that is proposed for generalized epilepsy. And there was actually just a research study summarized from the Melbourne team looking at this for Lennox-Gastaut epilepsy. So as we discussed, the dog had severe drug-resistant idiopathic generalized epilepsy. One of the things that was interesting is that the canine showed a diurnal seizure pattern. And so the orange marking, so that just to orient you, this is a 24-hour clock, so midnight, 6 a.m., noon, and 6 p.m. So right around bedtime, as the dog would fall asleep, it was actually at its highest probability of having a seizure. And those seizures would be clustered through the night. And then once the cluster started, so they would actually be grouping, they would kind of continue on and go around the clock. And so what we wanted to do as a therapy was to bias our stimulation and kind of maximize it to suppress these seizures in the evening, and then we could actually back off stimulation during the day. And so that's what's shown on this inner ring, is that we have the daytime activity where we turn the stimulation to one level, and then at night, when we're at a heightened probability of seizure activity, we would actually switch to a different stimulation level. Now, one of the reasons to do this variation is because you can induce side effects based during the day that you wouldn't necessarily have at night. So you want to do that kind of fine titration window. Now, the other thing we had was we noticed that once we were treating the seizures at night, they could actually slip over during nap times during the day. And so we also used the 3-axis accelerometer to measure when the dog was laying still for within certain parameters. And then we would actually say, we're assuming naps. And so we'd go into our seizure prevention mode. And then the last area, the outer ring, was always available. And that was actually tapping on the device. So just like your wearable accelerometers, you could tap on the device, and that would initiate an emergency program to try to abort a seizure that was ongoing. So with this system in place and the adaptation of this kind of time dynamic stimulation therapy with the motion overlay, we're able to prevent any further status epileptic events over the course of the dog's remaining life of 18 months. And then also, in addition, just the seizure activity itself and the clusters was significantly reduced. In the last year, we've also started to translate this into humans in investigational studies. So we have a study ongoing at Oxford. We call it MINDS. It's the motion adaptive deep brain stimulation for multiple system atrophy, specifically Parkinson's-like multiple system atrophy. And what we're doing here is the cross-section of placing the IPG, as we stated, in the cranial pocket. And then our collaborator, Alex Green, and the chief investigator for the project, places the leads into the PPN. And the notion there is to actually go in and stimulate at a level to help to drive autonomic activity. The objective is to stabilize blood pressure and also perhaps to improve gait in the MSA subjects. So once we have the leads placed, we'll actually use a EEG, and we can look for cortical entrainment and see how the PPN stimulation is actually engaging the broad cortex. And one of the observations we have is that we're actually can boost the endogenous rhythms in the brain with the stimulation. Now, the problem that can arise from this is that if we have the stimulation going and we're boosting these, rhythms related to being awake and aware, especially the beta band or gamma band regions, our subjects can complain that it's, yes, it can help them stay awake during the day, but it's preventing them from sleeping well at night. And so that's a big potential concern that needs to be alleviated. So the way that we've dealt with that is we've used the capabilities of the dynamo, in order to have a daytime mode, which is actually boosting up their levels in the cortical activity. And then at night, we actually turn the stimulation down, and we can get it to a level that allows them to sleep well, but doesn't actually compromise, that doesn't compromise their ability to go through the normal sleep stages. Now, that similar to the dog's napping mode, one of the concerns we have is that the subjects were to get up and need to go to the bathroom, that they might have a suboptimal therapy level at night for, when they really want to be up and active, and instead we're assuming they're asleep. So this is where we have another ring that's shown in kind of red, and that's if you break a certain posture and activity level, we can actually revert to the daytime programming while someone is up and about, and that gives them a level that we have higher confidence that they'll be able to ambulate and be aware. And then once they lay back down after coming back from the bathroom, we revert back into the nighttime sleep mode. So we're still in the middle of the trial. Some of the pilot results are coming out, though, and one of the things we're excited about is, especially in one particular subject who had very abnormal daytime sleepiness, based on the Epworth sleep scale, with the initiation of the stimulation and titrating it for cortical engagement, we're actually able to see a reduction from, in the middle of the abnormal range to now getting them right on the edge of normal sleepiness. And correlated with that is a reduction of their daytime naps, which are both, larger in number and sporadic throughout the day, to a fairly fixed frequency pattern of one nap per day at a fairly well-timed interval. So we're continuing to track these subjects over time and to continue to fine-tune these algorithms. But this is highlighting in two cases where making stimulation dynamic based on the time of day and kind of a rhythmic activity is a new degree of freedom for us to explore as a community. So a few quick notes as I wrap up is that one of the things we need to think about on any of these algorithms, both closed loop and circadian, is how we can maintain patient safety. So I just want to draw your attention to some work we've been doing applying ISO 60601-1-10, which is about physiologic control system design and control, and some of the best methods there for safety and how those can apply to a bioelectronic medicine device. So what's shown in blue are the classic closed loop systems, but in regulatory speak. So the patient transfer element is the physiological dynamic system of our research subjects and patients. Then we have our sensors, classifiers, and controllers, and our actuators. And then, of course, the command transfer element is a regulatory way of saying the clinician making the appropriate adjustments and what they want the device to do. The tan boxes are all of the things called out by the regulations to consider for a safe device. So understanding the physiologic dynamics of our patients, ensuring we have a fallback mode. So suppose a research subject says, I want to actually switch time zones or something's gone wrong. Do they actually have a way to disengage this smart algorithm in a way that's safe for them and go to a known set parameter? The other element that we put in state monitoring alerts to always give transparency to how the device is operating. So in the case of our circadian patterns, we have clocks, and we are very careful about synchronizing the embedded clock in the device with the outside world, and so that we know that the patterns we're giving are aligned to the desired patient's sleep-wake cycle. And then the last part is to ensure that we have actuation limits so that we don't go outside of safe operating zones. And that's both within the circadian state, but also when we're applying closed loop systems. So stepping back, I've shown examples from Parkinson's and Parkinson's-like multiple system atrophy, as well as a few snapshots from epilepsy. But I think for the community, this is a very general concept that we should consider, especially the fact that it really hasn't been explored much, as far as I can tell, in optimizing devices. But from a recent book from a colleague here at Oxford, Russell Foster, called Lifetime, this snapshot kind of shows you all of the symptoms of multiple disease states and other life processes, and health processes, and how those are actually kind of clustered at specific intervals during the day. It includes areas such as migraines, meningitis, mood disorders, stroke susceptibility, incontinence. I think you get the point. Temporal epilepsy. So as a field, as opposed to taking our therapies and thinking about them as the smooth continuum, what can we do to really understand the physiological processes and the rhythms underlying it, and how we might optimize devices? Because a real-time clock is available in basically every device we make. So to start to wrap, at Oxford, what we're doing is taking this baseline device, the PicoStim Dynamo, and starting to build up a therapy pipeline that explores both those closed loop concepts, but also a lot of effort going into chronotherapy and rhythm, how we might actually be managing rhythms. So some of the examples are the Cadet trial, which is a partnership with Great Ormond Street Hospital at UCL and King's College, looking at the device for the treatment of Lennox-Gastaut epilepsy in children. The disorders of consciousness for people with traumatic brain injury. It's funded by the Wellcome Trust. And then also looking at DBS for chronic pain with my colleagues Alex Green and Tipu Aziz and Martin Gillies. So all three of these trials involve disease states that might benefit from closed loop, but also importantly have circadian elements that might factor into the optimization of the device. So just to wrap up, kind of summary and contributions, I really want to reinforce that rhythms are central to life, and our new device technologies provide us unique access to both record these signals and get insight then into the rhythmic variations at multiple timescales. I really believe these rhythmic variations provide insight into both base physiology and disease process, and are influencing the efficacies of bioelectronic interventions. So stimulation parameters, control goals, we should perhaps synchronize to these rhythms and try and restore more healthy physiology. And for us as a community, I would really think we should consider, is this a future emphasis for therapy optimization? So we're exploring that question. We've developed a translational bioelectronic implant with our industry partner Bioinduction, based on their core technology. And the PicoStim Dynamo really enables us to do chronic clinical studies to explore therapy optimization across several disease states. And as I just showed, we have a therapy pipeline going on in the United Kingdom, and we're excited to start to kick off those studies and see what ramifications rhythmic stimulation might have on our patients. So with that, I'm happy to take questions.
All right, thank you, Professor Denison, for this very interesting talk and a very high-level overview of rhythms. Yeah, so let's see if Professor Lu-Ming Li's internet's okay to lead the Q&A session. Otherwise, I'll just check the questions from the audience and ask them and ask you for. Okay, so let's start from the first question from the audience. Dear Professor Denison, I have a question about the specific modulation of brain oscillation. As the brain oscillation is a network process, how do you link the brain oscillation modulation with specific neural circuits? And do you think that we can have selective modulation of neural circuits in human brain through frequency-dependent ways?
It's an interesting question. So one of the things that we look at, and it was hinted at with the EEG, is combining kind of a central depth target with more of a cortical measurement, and that gives us a sense of the coupling between these deeper targets and the overall cortical, the cortical map. And in terms of the engagement processes, so that helps us to get the networks and understand those networks, and others have explored network nodes to engage with DBS. But in terms of the stimulation, one of the things that we're finding that's quite intriguing is that we can entrain the brain if we are overlying specific stimulation frequencies with endogenous rhythms that are natural to that network. And so a bit to what you're implying is we're trying to see what control can we apply if we choose this frequency correctly to reinforce rhythms that we want to reinforce rhythms that are healthy and try to avoid or suppress rhythms that are pathological. So an example of that is that we've seen show up in multiple occasions is the gamma rhythm. In my own experience with Phil Starr at UCSF, we see that gamma activity that's endogenously there around 75 hertz. And then if you engage with brain stimulation, you actually will tend to pull that natural endogenous rhythm to the half harmonic. And we have a paper that's been submitted that models this with Wilson-Cowan equations, and it gives us confidence that it's not a stimulation artifact, but it's actually a true entrainment. And we see that also at other brain rhythms, such as the alpha band and the beta band, and we even see it now in our multiple system atrophy patients. We're trying to see, is that a degree of freedom to actually engage a specific oscillation and try to drive it if we want it to be there? So in the case of the MSA patients, we want to actually engage, say, the alpha and the beta band rhythms during the daytime, but then at night, we want to do just the opposite. We want to be pulling back, especially during slow wave sleep, and not actually driving those rhythms. So yes, I do think that we can refine our stimulation approaches to both reinforce healthy rhythms and try to avoid pathological ones.
I see. Yeah, I think the next question is also related to the multi-symptom atrophy patients. You mentioned the symptoms of 2 patients following a diurnal rhythm. How do you identify the diurnal rhythm is pathological or not? It follows whether we should surpass or enhance that rhythm. How do you determine?
Yeah, so when they're doing the assessments, and especially on one of the subjects, so of course each subject is slightly different. That's one of the, they have among the range of symptoms. And so they'll have, in some cases, they'll have excessive daytime sleepiness. And that's, is measured through the questionnaires and kind of the ratings and keeping track of their diaries. The other problem is complaints about sleeping at night. And that can actually be from a multitude of reasons, just the inability to sleep, but also the need to go to the bathroom multiple times through the night because of bladder challenges that can arise from autonomic dysfunction. And so what we do as our target is to try say vigilance during the day, and actually to treat many of the autonomic systems. You would say, I want to actually turn the stimulation up to as high of a tolerable level as we can have. That will help with daytime vigilance, and also to help perhaps with the autonomic side effects such as bladder control. But then at night, we don't want to have such a high level that prevents them from sleeping. So we want to actually perhaps turn the stimulation level down, but still to a level that will help with the bladder issues so that they can still sleep as much as possible through the night and not have to get up and go to the bathroom. And so it's an active area of research. These are the questions that we're asking ourselves and looking at the stimulation degrees of freedom that are available to us to do the optimization.
I see. Yeah. Another question asking about the stimulation treatments. The stimulation treatment achieved great progress in spite of very limited input data. Do you think the treatment will get improved with more information or more data, such as personalized rhythm and brain activity? If so, what type of information do you think might significantly contribute to the treatment effect?
Yeah, I think getting more of a snapshot on what are the inherent rhythms. I mean, if we step back, the rhythmic processes in our body exist because they're very good at making predictions. So it's like, I have a good sense that tomorrow morning in China, in Beijing, the sun is going to rise coming in the east, and certain processes will start, and your body actually can benefit. So physiology can benefit from predicting and then actually synchronizing these processes. And so as we study the inherent rhythms of individuals, both as individuals, but also then looking at how do they compare to a kind of normal or more typical, I would say, a more typical rhythmic process, can we actually nudge them into, say, a healthier process, but yet at the same time with the understanding of what is their personal physiology really doing? And also, what are their specific goals? So as a simple one is some people want to be getting up at 6 a.m., some people want to sleep in. And so we need to actually have the adjustment on a personal level to what the goals are of each patient as well.
I see. Yeah. There is another question which is quite general and probably needs some imagination, I think. What do you think the brain-machine interface systems will look like in 10 years? Are they going to become much smaller and with more electrode with multi-channels?
Oh yeah, I think they'll become smaller. I think, but also part of it's going to be what's the problem they're trying to solve. So that's the engineer in me, because I'd first say, what is the problem we want to solve with the brain-machine interface? And so if you want to do like a Parkinson's controller, like that Neuronic and Medtronic are exploring on the beta band, that only needs a few degrees of freedom for making the adjustments. And the NeuroPace RNS has 2 electrodes and it looks at force sensing channels. So I think for some applications that might be good enough. But as we get to more and more complex systems, want to get the bandwidth of this channel up, yes, I think we'll have to have more channels. I think we will also need to consider how we shrink it down, both to from an engineering standpoint, a surgical standpoint, and also actually a patient acceptance standpoint, make it so that it's more amenable to scaling up the therapy. That's one of the things we have to think about is in practice, how are we going to actually support multiple, implants, through the day compared to what the state of the art is today, especially like brain gates, a few going in a year. What needs to happen in order to make that brain machine interface go in, the tens of thousands to hundreds of thousands to millions per year, say in the future. So all the things that are saying, yes, scaling, energy management, information management, all those have to actually trend upwards. The point I'm bringing up though in this talk is a brain machine interface, and we have data from this actually now coming out of centers, is you need to consider what time of day it is for the brain machine interface. So if someone is sleeping, so suppose you hook someone up to so we say the imagination, suppose you hook somebody up into a robotic arm, and then you hook it up strictly to a certain area of their cortex. What happens when they're sleeping? What happens when they're dreaming? What is the state of that arm going to be? And how do the signals change? And so that's one of those things that we do need to think about, the time of day and some of these rhythms when we're even designing things like a robot arm computer interface or even a communication device. If you're signaling to your carers all night long and it's actually just you going through sleep patterns, that will be very annoying for everyone involved.
I see. Yeah. So we'll end with a also quick philosophical question. Will the implant affect the ways of our thinking?
I think subtly it can, and it will. Yes, I think it could absolutely impact the way that we're going about our cognitive processes. I think part of that is related to what brain networks you're going into. And so I think it's your perspective of what does that, what's behind the question and the nuances. But, when we look at treating disorders such as obsessive compulsive disorder, depression, especially in depression research and the like, in a sense, it is trying to subtly change the way that we're kind of going about our cognitive processing. And I think that's also something we have to be cautious of, even in movement disorders, where it's been shown some side effects in terms of risk taking and the like can appear if we have too much medication or too much stimulation and the like. Mm-hmm. But I think that's, in terms of the question, I'd say that's actually part of the goal from a certain point of view for many of the research activities going on. And and mood disorders. And as Professor Lee just showed in the case with addiction, it's, kind of taking away that reward from the cocaine in his example. That's a fine example of basically intervening in a cognitive process to take away from that reward. Okay.
Yep. All right. So conditioned on the time, we'll end our Q&A session for Professor Tim Denison. Thank you very much. And let's see if Professor Lu-Ming Lee is gonna be able to reconnect to the internet to make some closing remarks for your session. Yeah. Otherwise, we'll just end our whole session for brain machine interface and neuromodulation. Thank you, Professor Denison, and thank you all for attending this forum and this main speech talk.
Yeah,
all right.
Thank you very much for the questions.
All right. Thank you. Yeah. See you.